The topic today, I'm just going to pick 5 topics in neuro-ophthalmology that neuro-ophthalmologists are excited about. And there's been some developments that, for some of you that don't follow neuro-ophthalmology, you may not be aware of some of the new breakthroughs in thinking in these areas. And I'm hoping you'll find at least a couple of them that will be useful in your practice. And just a disclosure that I'm a consultant speaker for Teva Pharmaceuticals. So the topics are, in this order, photophobia or light sensitivity, OCT use in MS, which Dr. May has spoken of at other grand rounds, but I'll do a briefer version about that. NMO, or what used to be called Devic syndrome, idiopathic intracranial hypertension, which used to be called pseudotumor cerebri, and finally, the one not to be missed, giant cell arteritis, which should be on everyone's mind many times when seeing unknown patients with curious presentations. So we'll jump in with the photophobia. And if there are any neurosurgeons here, and this is something that all of us who are in the neurosciences as clinicians see all the time. I know you do. The headache specialists with migraine patients, virtually everyone has some degree of light sensitivity. It can trigger migraines. Blepharospasm patients universally say it triggers blepharospasm. Anyone who's had brain surgery, subarachnoid hemorrhage patients, pituitary resections, or traumatic brain injury, closed head injury patients, almost universally have complaints of light sensitivity that are often brought up by the patients themselves without eliciting a history. And particularly, it's not just any kind of light. They are very sensitive, particularly to fluorescent lighting, like in here, and also the canned lighting that's at Costco and those types of stores, the gas halogen overhead lighting, not so much natural light or incandescent lighting, which unfortunately I think has now been outlawed by the government at some point, right? It's supposed to, the manufacturing of incandescent bulbs is going away slowly, perhaps. But these patients come in, particularly to the ophthalmologist, and there's a few in the room, and have fairly unremarkable eye exams. So they often get diagnosed as having dry eye syndrome, and they may have concomitantly dry eye problems. So it's always good to address that. They may have blepharospasm. That sometimes gets overlooked. So it can be a trigger for blepharospasm, which is treated in a different manner. And a lot of times the patient's sitting in your exam lane in the dark with dark glasses on. So, if that's not a functional patient, it may be a photophobic patient. So, in the old days, we just really sort of dreaded seeing these patients, and we didn't really have much to offer them, and we didn't have even a good explanation for why are they even sensitive to light. But the biology of this is just taken off in the last 10 years. There's been a lot of publications, and they have discovered some cells in the retina that were not known when I was studying neuroanatomy, called intrinsically photosensitive retinal ganglion cells. They're commonly known as melanopsin cells, and they're about 10% of the retinal ganglion cells are this type. They set your circadian rhythm. They are partially responsible for pupillary constriction, and they project to the thalamic pain relay center in the brain. So they have to do with the sensitivity and the discomfort with light sensitivity. And in these cells are called melanopsin cells because they contain a large amount of melanin when you stain for it. And they can be easily distinguished from rods and cones by staining technique. So they are super sensitive cells, particularly with a peak frequency of blue light, which is about 480 nanometers. And when they've looked at patients who are blind, like from RP, retinitis pigmentosa, you wonder why are they light sensitive? Because they're blind, they have night blindness, but they've shown that the melanopsin cells are completely healthy, whereas the rods can be completely wiped out. So it sort of explains why a lot of blind patients are very light sensitive despite very poor vision, which I've always wondered about for years. The schematic of the retina, just to remind the neurologist a little bit, but looking from the outside in the retina, the rods and cones are at the back here, and in the front of the eye, right under the neurofiber layer, which we're going to talk about with OCT, are the ganglion cells, and here's these IPRGCs here projecting by the schematic up to the brain, to the thalamus or the pain relay center, sometimes to the dorsal midbrain where pupillary control is resided, and also suprachiasmatic nucleus, which has to do with circadian rhythm control. So here's another cartoon. There's a lovely review article about this by Kathleen Degree, my colleague at University of Utah, if you're interested in this, published in a couple different places, just showing that most of these fibers project via the optic nerve to the thalamus, but there are also other pathways thought to be from the iris and other parts of the eye that are not through the optic nerve as well. And then there are circuits that develop from the thalamus to the cortex and to the trigeminal ganglion, so you can stimulate, like with migraine, you can stimulate tearing and watering and nasal congestion and all the things that you sometimes see with migraine via the light circuit, light sensitivity circuit. This schematic shows different types of light, so you can see the spectrum on the bottom here in nanometers. And incandescent light has a nice bell-shaped curve, which peaks here around 650 nanometers. But fluorescent lighting has these spiky peaks, which you can see here. Mike, could you get me some water, please? Thank you. So there's these spikes, which are thought to precipitate the light sensitivity. Why fluorescent light is so evil for photosensitive patients. So what do we do about it? Because of this peak sensitivity of these cells at around 480 nanometers, in 1989 in England, they discovered a tint that they found would block the transmission of light in this narrow spectrum, particularly of blue wavelength light, and that patients who wore these glasses, when you did subjective ratings of light sensitivity, were far happier with these versus regular sunglasses. They also did this with blepharospasm patients and migraine patients in a blinded fashion. And it's been clear that these FL41 tints are the way to go and really do work. So they're available locally. A person can take a normal pair of glasses and have the tint applied as a dipping. They can also order them online as wraparound glasses. I found that it's really the only thing that works well for people with light sensitivity. Migraine, if they have migraines, you can treat the migraines, but a lot of times the neurologists just prescribe migraine medications, and it doesn't really help the light sensitivity if they're not having headaches. So I find that some of my colleagues know about it and other neurologists don't know about it. It's a good thing to know. There's local distributors for it. There are imitations of it. And there are some high-end FL41 distributors like Axon Optics, a few other companies online that are involved in making high-end versions of this. But it's a patented substance. So it's very helpful, and I think I think it helps to discuss the physiology with patients. If you're going to sit down with them and they're complaining about, to say, we understand what's going on, we have a better understanding why you're light sensitive. Here's a possible item that might help lessen the light sensitivity. It won't cure it completely. We advise patients not to wear very dark, dense sunglasses indoors because the retina becomes dark adapted, and then as soon as they step into bright light, it even makes things worse. And then they become housebound. They won't go outside. It becomes a real social quagmire of light-sensitive patients. And I'm sure some of you have seen those kinds of patients who can't function in society or work because of light sensitivity and migraines. So we'll come back. We can answer questions about that later, but that's sort of a very brief overview about light photophobia and light sensitivity. The next topic is going to be MS and the explosion of literature on OCT, optical coherence tomography, and there I am sitting with the machine that we use to acquire the images. And the OCT was first used, it was developed at MIT by some of my other colleagues at Mass Eye and Ear and other folks in the East Coast for glaucoma use initially, and it's been applied widely to all sorts of ophthalmic conditions besides glaucoma, retinal disease, optic nerve disease, corneal disease, many different applications. So when we were talking, we're interested in optic nerve function, particularly in MS patients, and we have a lot of ways of assessing optic nerve function. The two that have really caught on lately are low contrast visual acuity testing, which is not traditionally done by most eye care providers, ophthalmologists or optometrists, and then OCT. We still have the other tests, the standard 100% acuity, which most eye doctors use, color plates, visual fields, VEPs, which the neurologists like to use. And of course, looking at the optic nerve is not a bad idea either, although it's getting harder to train folks to use the direct ophthalmoscope well these days. So mostly we're taking photographs of the back of the eye. So when we've looked at optic neuritis patients, contrast sensitivity is one of the things that's uniformly affected adversely with optic neuritis in the affected eye. And in the optic neuritis treatment trial, which was a 15-year longitudinal study that I was involved in as an investigator, about a third of the patients at 10 years still had demonstrable abnormalities in low contrast vision. So it doesn't recover as well as the 100% acuity, color vision, and visual fields. In fact, it's the most likely to be persistently abnormal. And you use low contrast vision, patients use this in non-optimal lighting conditions. So driving at night, driving at dawn, reading in a dim room, that's when you're using the low contrast system. And they often, when they have impairment, they have difficulty, particularly with driving at night. That's one of the first things that patients voluntarily restrict. This shows you kind of the difference between a 100% contrast chart on the left, our traditional wall chart in a family practice office per se, and the newer low contrast charts. We have ones that are LED screens like this that we use. You notice that they've improved a lot of things on eye charts. The old charts with the big E at the top and then 2 letters, 3 letters, well, a lot of patients memorized those, and there were a lot of inconsistencies in testing with those types of charts. So the newer charts based on diabetic research studies have the same number of letters per line, and they're evenly spaced. The old charts had different numbers of letters. They weren't evenly spaced. It was much easier to guess certain letters than others. So the charts have improved considerably, and the low contrast comes in different degrees of contrast, 2.5, 1.25, 4%. You can set the contrast you want to test. And in clinical trials, they typically will pick 2.5% or 1.25%. Laura Balser is a neurologist at NYU, chairman, and she has sort of pioneered the use of low contrast vision as an adjunctive parameter in monitoring MS patients. And she's shown that it's much more sensitive than normal contrast in assessing vision. So the next thing I want to discuss is the use of OCT, which complements the low contrast vision testing. So if we look inside the retina, you see on the right here, you see a little cartoon of the retina, and the surface of the retina has axons that form the nerve fiber layer, which originates from the ganglion cell layer. That's the second layer down. And the rods and cones are at the back of the eye, of course, looking in this orientation. So the OCT, for our purposes, is measuring the thickness of the unmyelinated axons just under the surface of the retina in different portions of the eye. This is an actual microscopic view of the retina, and you can see how thin the nerve fiber layer is on top, and the ganglion cell layer is often measured with the next layer, the inner plexiform layer. The machine can't segment those apart yet, eventually perhaps. So right now those will be combined, and you'll see GCIP. That's those 2 layers together versus the nerve fiber layer on top. And then, of course, the rods and cones again are down here at the bottom looking in. So the machine is easy to use. It only takes a couple of minutes per eye to measure this. You don't need to dilate patients. You get a printout that looks like this, And it's quite simplified for us. I don't know, I think we're not so intelligent, but the appearance here is you see the right eye and left. It's broken down into quadrants. The machine has tested thousands of people, so we know what the norms are for the sex and age of the patient. And we have norms down to about age 18. So here's a normal eye, and you'll see on the wheel, we don't really think that the 8s are very accurate, although I don't know why they put it on the printout. So we look at the quadrant analysis, and you want to see green is normal, yellow is outside that 5% range of borderline abnormal, and red is generally thought to be thin or abnormal. White is actually slightly elevated based on norms. So this is a normal one. After optic neuritis, if you wait 3 to 4 months, because it takes time for the thinning to develop, especially if a third of the patients have swelling of the optic nerve with an acute attack of optic neuritis, you may see thinning, and the most common quadrant that thins is the temporal quadrant, unlike patients with ischemic optic neuropathy, which is usually the superior or inferior quadrants, and that's why they get altitudinal field cuts. So looking at the optic neuritis treatment trial with OCT, there was a subgroup analysis, and we saw that the temporal quadrant is the most common area that's affected in optic neuritis. So that's more, it helps us sometimes differentiate, is this a patient who's 50 who had optic neuritis versus mild ischemic optic neuropathy? This is where the OCT might be useful. And then in chronic patients with MS, and we have, thousands of them here, even without a history of optic neuritis, their vision may dwindle, a chronic optic neuropathy. And you see the best corrected visual acuity is no longer 20/20, and it's not just due to cataract. It may be down 20/50, in this case 20/80, and in those cases you'll see the averages of the quadrants here are dropping down. This patient was 58 on the right and 70 microns on the left. And you can see on the quadrant analysis, there's a mixture of normal, abnormal, and borderline thinning. So that is not uncommon. The other things that have been learned from publications are that the nerve fiber layer thins, even though the vision subjectively gets back perhaps to normal. The OCT is so sensitive that it will show often persistent thinning that we mostly think is irreversible. I mean, I guess we don't know 100%, but it seems unlikely that it's reversible. We also noticed that there's thinning in contralateral optic nerve, and we've known since the ONTT that optic neuritis, when it seems like it's one-sided, often you see abnormalities in the other eye in visual acuity, in visual field, and especially contrast sensitivity. So I'm not surprised to see that maybe optic neuritis in adults is not so one-sided as we have been taught. In children, we say it's universally bilateral and severe, often with a swelling of both optic nerves. And in adults, it's usually unilateral, and we only see disc swelling in about a third of the patients. But OCT is teaching us that, in fact, there's often involvement of the normal other eye in acute attacks of optic neuritis. But you have to wait 3 to 4 months to see that on the OCT with retinal nerve fiber layer analysis. And it's been found to correlate very highly with acuity, particularly low contrast acuity, visual fields, and color vision testing. Dr. Costello, who's my friend and colleague in Calgary and a big MS expert, and she's a neuro-ophthalmologist as well, published a landmark paper that showed, just to look at this graph, it's not terribly complicated, but on the horizontal are the nerve fiber layer in microns, and on the vertical are the visual field depth of the defects. From top to bottom, as the field gets blacker and blacker, the numbers become more negative, 0 being a normal field. And you see that as the nerve fiber layer drops off to around 75 microns, you see the curve change to a more steep projectile, and that's when the visual fields start to plummet. So as the RNFL drops below 75, she found in her patients that the visual fields then dropped off. So you can see a lot of nerve fiber layer loss before the visual fields will show a lot of abnormality. It's just much more sensitive. And it also seemed in her study that 75 microns was sort of a time when patients began to complain about their vision being always abnormal. And I bring this up with my patients. We kind of look at that number. When it's less than 75, their vision may fluctuate day to day, moment to moment. Their eyes poop out. They get tired if they do a lot of visual work, and I tell them to rest. If they have an average thickness of 60, they're going to complain to their neurologist and ophthalmologist that their eyes get blurry from time to time. And it may not be dryness. It may be their optic nerves are just kind of pooping out because they've reached this threshold. So it's a good number to keep in mind. We also know that there is a natural thinning of the nerve fiber layer in adults. In a person's lifetime, it's said to drop around 10 to 20, maybe 30 microns from age 20 to age 80. So that's about a 0.2 micron drop per year with aging. When we've looked at MS patients longitudinally, and there haven't been a lot of studies, there was one that looked about 5 years. It was about 2 microns per year. That's 10 times higher loss of nerve fiber layer than normal aging. So this correlates somewhat, we think, with what we see with brain atrophy, which is accelerated in MS patients versus non-MS patients. There's a similar accelerated thinning of the brain tissue and atrophy. Now, the latest thing, the new thing, has been the onset of segmental software for certain machines, OCT, for isolating the ganglion cell and internal nuclear layer, that area together, primarily as the two together as a marker of axonal loss. And studies that have been looking at this and comparing it to nerve fiber layer have shown that it seems to be more sensitive and it's affected earlier. I'll give you an example. When we've seen patients with acute blindness from Leber's optic neuropathy, and that's not a demyelinating disease per se, it's mitochondrial, but the ganglion cell layer, as these patients acutely drop to count fingers vision, the nerve fiber layer is normal, but the retinal ganglion cell layer will drop out immediately to complete red in all sectors. So it's affected earlier, and then after 3 to 4 months, you will see thinning of the nerve fiber layer. This is an example of GCL, called GCL analysis, and you look at these as if the patient is facing you. So on your left is the patient's right macula. And if you look at this one, instead of quadrants, is done in 6 sectors on the macula. So it's a larger area of analysis than on the optic nerve. And you see this is completely wiped out in the right eye and completely normal on the left. So I would expect, if this was an MS patient, that this patient might have decreased low contrast vision in the right eye to go along with this. The normal contrast might be normal, and the fields might even be normal. So there have been a few recent studies looking at GC versus nerve fiber layer analysis. And what we've seen is that the progressive patients seem to have the most advanced thinning of the ganglion cell level analysis. And it may correlate better with disability and low contrast vision than nerve fiber layer. But we use both. They don't always correlate, as you can see. This is a study that was published in Neurology, a large number of MS patients, and they saw the fastest thinning in this ganglion cell layer in the patients who had the most active disease, the most relapses, the most new enhancing lesions on MRI, and those who had the fastest disability progression, particularly if they'd had diagnosis of MS less than 5 years. This is a recent publication just last year. It's a longitudinal 4-year study at Johns Hopkins with a smaller number of patients. They did an MRI annually and OCT every 6 months, and they saw that the atrophy of the brain was mirrored by the thinning in the nerve fiber layer and ganglion cell layers on OCT. And in fact, those who had the fastest rates of thinning on OCT had the greatest amount of whole brain thalamic and gray matter atrophy over a 4-year window. So it's been advocated that OCT be used as an adjunct to monitor MS patients on a more regular basis. This is still controversial, but a lot of centers are doing more and more of it, and we're certainly doing quite a bit of it with some of the MS patients at our center. Okay, so I'm going to switch to talk about NMO, which used to be thought to be a subset of MS, and now we know that it has a different pathology and it's a different disease, and in fact the treatment regime is probably quite different in many regards than many of the drugs that are used for MS. The disease was described by several people, but it's been attributed to Eugene Devic, whose name was originally associated as Devic syndrome, and now we prefer NMO or neuromyelitis optica as the clinical entity. So the features of this disease, it has a predilection for optic nerve and spinal cord with acute relapses and visual loss versus weakness from spinal involvement. The optic neuritis is often very painful and severe visual loss frequently with poor recovery. So it behaves differently than ordinary optic neuritis, not always, but many times. And in the myelitis patients, we've discovered they also have sometimes refractory hiccups. And I've had a patient with that where it was the main clue to the diagnosis of NMO was hiccups that went on for weeks and weeks and weeks due to involvement of the upper brainstem and regions that involve hiccuping. In the textbook traditional descriptions, the disease was monophasic, but now we know that the majority have relapses. That's where they are similar to MS patients. And you had to have originally a simultaneous onset of optic nerve and spinal cord involvement, but now we know they can be years apart, and you don't always have to have both optic nerve and spinal cord involvement. It may only be on one side of the eye. You may have brain lesions. Originally, it was thought to have very little involvement of the white matter of the brain on imaging. And often those lesions, occasionally those lesions mimic MS lesions. So it's not uncommon to have lesions of the brain with NMO. This is an example. But only about 10% have lesions that mimic MS, in fact. And in children, you may see involvement, particularly in the diencephalic areas and brainstem. These are all examples of the presentations of imaging with NMO patients. So you see predilection for the midline, upper brainstem, area postrema, where they get nausea and vomiting, and spinal cord with these longitudinally transverse, long extension of lesions in the spinal cord, and then sometimes brainstem as well. And then large confluent areas like this that you can see that look like PML or other entities sometimes. So in the old days, this is not so long ago, but 2006, the criteria, you had to have a history both of optic neuritis and myelitis, and then you had to have either a positive antibody for NMO, or you had to have these other criteria, a brain scan that didn't look like MS, or you had to have a longitudinally extensive spinal cord lesion. The antibody was developed by Van de Lennen at Mayo, and most of you probably know that story. It's a fascinating story, and we'll talk a little bit about it, but it was serendipitous about how it was discovered. So now we talk about NMO spectrum. So we have recognized over the last decade that patients don't fit in these neat categories for diagnosis. And some of these patients have had primarily longitudinal involvement of the cord. Some have had severe optic neuritis with poor recovery. There's a whole subset of Asian opticospinal MS, which is probably NMO, and then some overlap with lupus and Sjogren's, where they may have both diseases. The new criteria, you really only have to have one of these core presentations, like optic neuritis or acute myelitis or brainstem syndrome, and a positive antibody. The antibody is so specific, as you'll see, that pretty much clinches the diagnosis if you have one presenting symptom. For the negative patients, it's a little bit more complicated, as you see. You have to have two of those core characteristics, like optic neuritis and myelitis, and then it has to have these other criteria met in terms of the MRI. So the antibody test now, it's done at a couple of places, 2 or 3. The best one is done at the Mayo Clinic, and that's because it has the highest sensitivity, which you see is around 76%, and over 99% specificity for the diagnosis. So we have talked to the lab at Swedish at all. If we order an NMO antibody now, they were sending the ELISA antibody. Now they're sending the cell-based assay to Mayo, thanks to Dr. Rapovic, who pioneered this with LabCorp to get them to switch to do the more reliable and precise antibody test. So I think they're all going, if you order them within Swedish through LabCorp, they should be going to Mayo, which we think is superior and gives a little better outcome. So when you look at NMO optic neuritis patients, one of the groups that has NMO are patients with recurrent optic neuritis. And about 50% of these patients who end up antibody positive have developed transverse myelitis over the next decade. So if you have an optic neuritis patient with poor recovery where you suspect this, you want to check NMO, because you'd hate to have them get an attack of transverse myelitis and have paralysis, partial paralysis for the rest of their life because we didn't know the diagnosis in advance. So it can present initially with optic neuritis with poor recovery. This is a study that was published by my mentor at Mass Eye and Ear of 3 women with recurrent optic neuritis and positive antibody, followed for up to 12 years, but none of them developed transverse myelitis. So there may be this is part of the spectrum, or maybe they'll never get transverse myelitis. They were not treated, they were just followed at that time, and they didn't develop spinal cord involvement. So there's always exceptions. Who should we test? Patients with spinal cord involvement who have longitudinal involvement over 3 segments or longitudinal involvement of the cord, and patients with unilateral or bilateral optic neuritis, particularly with severe visual loss or poor recovery. And those who have big dropout on OCT. We're talking about 15, 20 microns after an attack of optic neuritis or greater. How do we treat it? Well, that could be another lecture. Generally, patients are treated like optic neuritis with IV steroids and or plasmapheresis, and then often some type of prophylaxis, not using the interferons. Those have not been felt helpful. They may be harmful to these patients. We usually use Cellcept or azathioprine with steroids, and sometimes we use Rituxan infusions as well. And newer drugs are being tested also for treatment. Okay, I'm going to talk a little bit about pseudotumor. There was a very large clinical trial that I was the PI on regionally for the Seattle area, and Dr. May was an investigator with me. And this has been published in Neurology, but there have been updates because the study went on for an additional 3 years, and the papers are still being published and coming out of our findings about treatment of IIH, or what used to be called pseudotumor. So just to start with the first, a typical patient, 37-year-old obese woman with headaches, visual graying out, pulsatile tinnitus, large weight gain. Central acuity is down slightly, grade 3 papilledema. She has an enlarged blind spot on the left and a secocentral blind spot on the right. And OCT, which is starting to be used for monitoring papilledema and to help distinguish from pseudo-papilledema, showed marked swelling of the optic nerves. You can see on the scales at the bottom here that it's off the charts. The elevation of the retinal nerve fiber layer is not even plottable on here. It's so high, particularly superiorly and inferiorly. These averages are, the machine becomes inaccurate after you get up to a certain point of elevation. It can't accurately measure the swelling with papilledema. And she had a normal MRI and MR venogram with a high opening pressure, treated with acetazolamide with resolution of symptoms. And you see she had a nice outcome, and I wish they all had this nice outcome. So, of course, we see a spectrum of the very severe patients, people who can't tolerate medication. There's quite a bit of pregnant patients. I have 2 or 3 right now with this disease. This one did very well just with weight loss and medical treatment. And the OCT normalized, but there was some leftover thinning after the swelling resolves, and that is not uncommon. So for the study, we had patients internationally between 18 and 60 who had strict criteria met for IIH. and had mild to moderate papilledema based on visual fields and fundus photography. Patients, we had 165 patients that were actually included in the study. We screened far more than that, and many dropped out or were excluded. They were randomized to either acetazolamide in varying doses or placebo, and all participated in weight loss through the Columbia University weight loss program. And we wanted to know whether acetazolamide plus weight loss was superior to placebo, just weight loss alone, because acetazolamide had never been proven to be effective for management of the disease. So we had 165 patients, only 4 men. The mean BMI was 40, and there were some with family members with IIH. The graphs show here that there was improvement in the visual field measurements. As you'll see here, the mean PMD is sort of how abnormal the field is. The more negative, the more abnormal. And both groups improved, but with the addition of acetazolamide, much faster and more complete at 6 months. If you looked specifically at the high-grade papilledema, grades 3 through 5, there was a much greater effect of use of the addition of acetazolamide. There was a 2.27 decibel increase. And that's a pretty substantial improvement in the field versus placebo, where there really wasn't any improvement versus placebo. In that group, the placebo didn't do very well. If you look at papilledema, you see the papilledema gradually resolves with diet alone, but you add in acetazolamide, and in the first month, there's a significant separation from the diet alone curve that improves out to 6 months. So weight loss, we saw twice the weight loss at 6 months by adding acetazolamide. And even in patients who did not lose weight, we saw these improvements. So we think that the medication works independent of weight loss. But patients do often lose weight while on medication. We looked at spinal fluid at 6 months in as many as would let us do a second spinal tap, and there was about twice the lowering of the opening pressure on spinal tap at 6 months with the addition of acetazolamide. The doses ranged from, by tolerance, 250 to 4,000 milligrams a day. The average dose was 2,500 milligrams, and 40% were on 4,000 milligrams. So we have issues with pharmacists. We've got patients on 2,000 to 3,000, and I routinely get calls or my nurse saying, you're trying to poison this patient, And every time I order on Epic anything over 1,000 milligrams of Diamox, I have to say the benefit outweighs the risk. Benefit outweighs, routinely, because it thinks that it's a weight. We monitored patients for systemic side effects by blood testing, CBC, electrolytes, and found that there weren't any in all of these patients, so we don't routinely recommend lab monitoring. It seems safe. We were told to use the largest dose that patients would tolerate. There'll be more publications about the differences in the doses and the outcomes that haven't been published yet, so a lot of papers are going to be coming out. So overall, what we found is that, as you know, acetazolamide worked. It worked independent of weight loss. It improved visual field, papilledema, quality of life, and CSF pressure. It was tolerated and safe. So the paper that was published said that it recommended maximally tolerated dosage of acetazolamide. Now, that's not what I personally do, and I don't think Dr. May does either. We have a pretty good idea of, depending upon how severe the papilledema is, what to start with. I think an average starting dose is getting the patient up to about 1,000 a day, either in divided doses or all at once. With younger patients, if I'm worried about compliance, we do it all at night, sometimes large doses all at once, rather than have poor compliance. So there's lots of little tricks, but it's a tricky disease. The next study that's being planned that we will participate in, it will be for moderate to severe papilledema presentation. It will be a 3-arm trial of medication versus shunting versus optic nerve sheath fenestration. So that is in the planning phases, and we hope to be a part of that since we were one of the largest recruiters for this study, the one I just talked about. And the last disease, which is perhaps the most important, because the cost, if the diagnosis is missed, is quite substantial for the patient, and it's a common source of lawsuits also, unfortunately, because of the consequences are so severe with blindness if the diagnosis is missed early on. So here's a case, personal case. I see a lot of these, but this was a Parkinson's patient sent to me for double vision a year and a half before. I thought the double vision was related to Parkinson's, helped him with some glasses. Calls me on a Friday, says he went blind in one eye for 10 minutes. And what do I think about that? So, of course, I said, go to the Swedish emergency room immediately, which he did. He went to the ER, and he was told he had a migraine. He had no blood tests done, no blood work. He's 64, so he may be not thinking of giant cell. But he called me the next day. He said, well, I went to the ER. They told me I had a migraine, and that's all we did. We didn't do a Doppler. We didn't do lab work. I had a migraine and sent me home. So, of course, I was concerned about that. I ordered a Doppler study of the neck. I sent him for SED rate and CRP. The SED rate was 64, and his CRP was 97 almost, so significantly elevated. Well, I wrote here, what would you do? But I think I know what most of you would do. You give the patient steroids and arrange for a biopsy. The concern is GCA, right? So I put him on 80 of prednisone. Now, sometime if he'd had visual loss, I probably would have given him IV steroids instead. And we arranged for a bilateral TA biopsy. The primary care actually asked for a bilateral, and then we can discuss that, whether to do unilateral or bilateral. It was equivocal. So I got the report after he had no more episodes. It showed some focal inflammation, but they read it sort of as negative. It was not diagnostic of GCA. So, this is something I've learned over the years. This might have been done in Friday Harbor, not to pick on them, or who knows where. But, you can ask for the block. I can ask my friend Dr. Rostad here, who I trust, to look at it again. Recut the sample, retest, look more carefully, more slices. And many times he will call me up and say, you're right, it's GCA. So we did that, and it was consistent with GCA. So we managed him on a long-term prednisone tapering with no visual loss. So I've had 2 or 3 where I've actually caught them with transient amaurosis and prevented blindness. And this is more typical than non-arteritic AION, where you don't get premonitory temporary blindness. So it's something to think about. And you always have to be thinking about GCA when you see these patients, particularly with either double vision or transient visual loss. You should be thinking about GCA. Anybody over 50, certainly. Visual loss is the worst complication. It occurs in about 20% of patients despite steroids. And if you don't treat them, the other eye the majority will have visual loss bilaterally in the other eye within hours or days, if not weeks. In over 50% of the cases. So at NANOS, my neuro-opht meeting this year, there was a presentation from the Mayo Clinic of 245 cases of GCA. They found 8% had permanent blindness. The majority, 7%, were AION cases, and some were central retinal artery occlusions, a smaller percent. 20% of the patients had no other symptoms of GCA presentation, so-called occult GCA. They just present with blindness. So you can ask them all the GCA questions, but if you don't check the SED rate and CRP, they may go on. Then you have both eyes gone, and you say, I wonder if that was GCA. Double vision from GCA. We don't often think of it, but we have had third nerve and sixth nerve palsies, and then sometimes just the extraocular muscles involved where it's not a cranial nerve palsy. I've seen it myself in one of my colleagues who's ophthalmologist, so, it happens. I've seen it several times with just double vision as the first symptom of GCA. So it's something to think about as well. As far as the things that are pathognomonic, we think about chalky disc swelling without the typical peripapillary hemorrhages of non-arteritic AION. Any retinal ischemia is highly suggestive of visual loss from GCA. I always feel the temporal arteries. I don't know if you guys do, but when I have a patient where I'm even thinking about it, I check the temporal arteries to see if they're tender, if there's pulses. I had a person who did a lot of the biopsies has said, I've never met a patient that didn't have tender temporal arteries that that had positive biopsy. So, but I don't think it's absolutely reliable, but I would do it. And then I always send CRP and Sedrate. And I get called a lot about these patients, or I see them secondarily, and they have not had CRP checked. And I'm not talking cardiac CRP, just a regular generalized CRP. CRP is more sensitive than Sedrate. And I have had many patients with so-called normal Sedrate for age in the 30s with a high CRP where I've biopsied and it's been positive. As far as biopsies, I usually order unilateral. The Mayo Clinic likes to do bilateral. If it's negative and I strongly suspect GCA, I will have the other side done. And if I don't believe the biopsy results, if this patient just has a lot of symptoms, I'll have it redone by pathologists I trust. And occasionally, I have treated despite negative bilateral biopsies, and the false negative rate with bilateral is less than 5%, probably 1 or 2%. You have to go with your clinical gut impression. So if you absolutely think the patient has GCA, it might be best, perhaps with the assistance of a rheumatologist, to treat. So GCA is a tricky one, and you just have to constantly be thinking about it and be on the lookout for it in your mind. Treatment, the current treatment based on a review at my professional society is IV steroids for visual loss. If you don't use IV, you can't talk the patient into coming into the hospital, then oral steroids, usually 80 to 100. We don't think 60 is adequate, which is used for headache management with GCA. And I have seen patients go blind, and they have been in the literature on 40 to 60 for GCA for headache, and then they go blind because they're not on an adequate dose. So if you have visual symptoms, 80 to 100 or IV with a prednisone slow taper, 10% a month decrease perhaps. And then of course we put aspirin. We don't think Coumadin or heparin is particularly helpful. Very slow taper. Biopsy on everyone. I generally don't skip the biopsy because people develop hip necrosis and problems with steroids, and if you don't have a firm grounds for putting them on steroids and taking risks with that, good luck. So I think it's a good idea to do the biopsy. And then those that can't get off steroids, the rheumatologists are quite good at finding substitutes, like methotrexate has been fairly successful too. So that's kind of where we're evolving with treatment. The hit hard and hit fast was from Valerie Bius at Emory. She gave a nice lecture about this, and she emphasized that, when you send the patient to be hospitalized, perhaps if they're blind in both eyes from GCA, and you call in the IV steroids, you don't let them deliver it when they get to the floor. You call the ER and say, have it hanging and ready, and as soon as the patient arrives in the ER, you get the IV going. Because it could sit there until 8, 12 hours waiting to be given on the floor. So you have to talk and follow through on these patients. The latest thing, which is controversial, is Don Gilden at University of Colorado has looked at positive biopsies and found a high incidence of varicella-zoster antigen and thinks that zoster recurrence may be a possible cause of GCA. 8% of the controls also were positive, so we don't know what to make of that. But they have, in neurology, they have brought up the possibility of adding antiviral therapy to steroids in acute cases of GCA. So I don't know, no one's really, there was an editorial about this. They said probably we don't know enough yet to definitely add antivirals. Some people will, some people won't. And it may be, if this is true, that the new shingles vaccine may decrease the incidence of GCA down the line, or that is possible. So we'll see where that goes. We'll have to see if that's confirmed by other studies. I'm going to stop. I put a couple of fun slides at the end. So this is for all the neurology people. This is in Biarritz at the Hôtel du Palais in Biarritz, which was built by Napoleon III for his wife Eugenie in 1855. There's a lovely seaside restaurant where I had dinner. And I saw the sign. I saw, the hippocamp. That's interesting. So you know what that is, right? You all know what that is from neuroanatomy. The seahorse and the lovely light you know, the outdoor lights are all seahorses there. So I thought, well, that's just terrific. That's a great neuroanatomical landmark, you know.